Heart rhythm lecture. I'm glad to introduce Andrew Ha, the hottest hands in Canada for atrial fibrillation ablation. It's said that when his hands come together, sparks fly sometimes. Andrew's going to tell you about who we should ablate and how, and give you an introduction. And the message here is he's going to give you a very realistic opinion on how this should be done. And Andrew.
Thanks. Yeah, thanks for the opportunity for me to talk in this symposium. I think we have three objectives today. The first objective is to review the procedural aspects of catheter ablation for patients with paroxysmal and non-paroxysmal atrial fibrillation. Our second objective is to discuss the use of the ablation technology in new or previously unapplied patient subgroups, such as those with heart failure. And finally, I want to talk a little bit about what it means to have a successful AF ablation from a patient's perspective. Some background. Atrial fibrillation is the most common form of cardiac arrhythmia encountered in clinical practice. And in many patients, AF results in symptoms such as palpitations, fatigue, or shortness of breath, which lead to impairments of quality of life, and they feel miserable. And as a result, we are very interested in trying to treat them so that they can feel better. The two main strategies to treating atrial fibrillation in patients of include rate or rhythm control. So one is the use of beta blockers or AV nodal blockers. The other is the use of antiarrhythmics or ablation. When you look at clinical trials, however, neither strategy is superior over the other with respect to improving survival. So therefore, the decision to apply rates or rhythm control is highly individualized, and it's based on symptom relief and improvements of the quality of life. This is a typical example of what rhythm control is. There are really two main options for rhythm control. One is the use of drugs. The other is the use of an invasive procedures like ablation. And this is a typical slide showing what happens with ablation when we compare it to antiarrhythmic therapy. As you can tell, the red box denotes patients who underwent ablation versus those who were treated with drugs. And you can see that patients who were treated with ablation had a much lower probability of AF recurrence compared to drugs. And multiple studies have shown this, and this is this kind of data which fuel the interest in ablation because it's probably much better than antiarrhythmic drugs with respect to maintenance of sinus rhythm and reducing the recurrence of atrial fibrillation. I just want to talk a little bit about the pathophysiology and mechanism of AF because I think this will let us understand why we're doing those things we're doing right now with respect to ablation in humans. I think the first message is that triggers are extremely important in the initiation and the pathogenesis of atrial fibrillation. There are multiple triggers in the left atrium which have been implicated to cause atrial fibrillation. I think the most well-established triggers are the ones from the pulmonary veins. It's believed that there's abnormal activity in the pulmonary veins which repetitively fire into the left atrium, resulting in atrial fibrillation. There are many other foci which may also be triggers in atrial fibrillation, but from clinically speaking and from ablation experience, it appears that triggers in your pulmonary veins are extremely important in initiating and resulting in atrial fibrillation in humans. And proof of concept is shown in a study in the late 1990s from France, which kind of opened up the door of atrial fibrillation as we know today. And this is the concept of ablating triggers within pulmonary veins. What they do is that they put catheters inside people's pulmonary veins, and they notice that there are signals called PV potentials, which are recorded in these veins. And in some instances, atrial fibrillation is initiated by these pulmonary vein potentials. So therefore, it leads to the concept that if we can somehow ablate these pulmonary potentials, perhaps we can eliminate the triggers for atrial fibrillation and perhaps reducing AF recurrences in people. And as a result, the field has matured to a state where we have consensus documents saying that the mainstay of AF ablation is to try to isolate the triggers in each of the four pulmonary veins so that the triggers cannot get to the left atrium and result in repetitive firing and henceforth atrial fibrillation initiation and genesis. I just want to talk a little bit about the technique of AF ablation in 2012. So generally speaking, when a patient is brought to the EP lab, we establish venous access in the right femoral vein. We put in a number of catheters, 2 of which will be in the left atrium. There will be an ablation catheter and a mapping catheter. We give intravenous heparin during the procedure because there's hardware inside your heart. The procedure can either be done with conscious sedation or sometimes under general anesthesia. A typical duration of the procedure nowadays is in the range of 3 to 4 hours. So usually we can do 2 a day. With respect to the technique, the concept is to try to ablate the vein so that the triggers cannot get into the left atrium. So that's the theory behind this. As you can tell, when you put a mapping catheter inside the vein, you can record potentials. And by using the catheter, it would guide us with respect to doing lesions around the veins. In position B, it's a position we like to avoid because it's a little bit too deep. So we usually burn outside the veins, but around the veins. So the concept is to create a line of block in the left atrium so that the triggers cannot get into the left atrium, hopefully reducing AF recurrences. I think with collaboration with our imaging colleagues, the use of imaging has been revolutionary in allowing us to do these procedures quickly and with minimal radiation. This is a CT scan of the left atrium done days before the ablation procedure with very accurate detail of the pulmonary veins and the orientation to each other. You can also do endoscopic views of the veins showing the complex topography of the ostia with respect to the left atrium. This map is a left atrial map constructed by putting a catheter inside the left atrium. And the use of the CT really gives us a great roadmap so that we can map into parts of the left atrium to exactly reconstruct the anatomy so that we can perform the ablation accurately, safely, and successfully. The way we do it is that the purple is the CT scan of the heart, and the green shell is the map which is created by having the catheter inside the left atrium and moving around it. So using the CT as a roadmap, we can tell which areas we have gone to, which areas we need to go. And then once we have built the map, we can then perform lesions around the veins. And the technology allows us to have real-time tracking of the catheters. And when we lay the burns, we can mark them so that in the end, we can review our lesion set to see whether there are any gaps and how many lesions have been done, etc., for the veins. I want to talk, in spite of the exciting procedural aspects, you have to be realistic. The procedure is not without risks. Generally speaking, we tell patients there is a 3 to 4% chance of a complication, most of which are fairly minor and resolve on their own. So the most common complication is vascular complications such as a hematoma, fistula, or pseudoaneurysm. Most of them resolve with observation. Very few of them need surgical intervention. There's a 1% chance of a fairly significant complication. The most dreaded, probably the most common, is cardiac tamponade because of catheters being inside the heart. You can also have a 1% chance of a stroke, stenosing the veins, damaging the phrenic nerve. The rate of death, or something called atrioesophageal fistula, is in a range of 1 in 1,000. Atrioesophageal fistula occurs because your esophagus is right behind your atrium. So you can imagine if you deliver too many radiofrequency lesions, you can theoretically form a connection between the esophagus and the atrium. But we really try to avoid that with judicious use of energy in the back wall of the heart. Let's talk a little bit about the outcomes for paroxysmal AF ablation. There have been so many trials done comparing AF ablation versus medical therapy that people have done meta-analysis on these things. And the message is that, in general, AF ablation is associated with a significant reduction of AF recurrence compared to the use of antiarrhythmics. So this is something we know and hold as very good proof in terms of reducing AF recurrence, ablation over the use of antiarrhythmic drugs. When you look at contemporary clinical trials of the rates of success at 1 year for AF ablation versus drugs, we see that the success rate of antiarrhythmic drugs is probably in the range of 10 to 40% with respect to reducing AF recurrence in 1 year, whereas in ablation, it's probably in the range of 60 to as high as 90. But in the 90% group, most people had a repeat ablation. So realistically, the rates of success is probably in the range of 65 to 70% after one procedure for paroxysmal AF. And by clinical success, what we mean is no AF without the use of antiarrhythmic drugs. And the rates of a repeat ablation, this is a fairly realistic representation, about 15 to 25%. So about 1 in 4, 1 in 5 patients will need a repeat procedure to try to get rid of the AFibs. I want to talk a little bit about, so that's for outcomes for paroxysmal AF. How about for persistence? So the definition of persistent AF are people with more long-standing atrial fibrillation, more than 7 days or needed cardioversion. And it's believed that these people have more advanced disease in that besides triggers, there may be scar in the left atrium or some sort of myopathic process in the left atrium causing the perpetuation and the sustainment of atrial fibrillation. When you look at meta-analysis of AF ablation in persistent people, the message is fairly consistent. The message, I think, is that the single procedure efficacy is probably less than 50%, and the rule of thumb is that you probably need more than one procedure. So it's a different animal than paroxysmal atrial fibrillation, and I think it reflects the more advanced disease states of these patients in the atria compared to those with paroxysmal AF, with the understanding that if you leave most patients in paroxysmal, they tend to progress into persistent. So the concept, perhaps, is that we should take them earlier before they progress to persistent, because then it makes the job harder, and also the success rate's lower. And in terms of the guidelines, what do they say? In the 2010 Canadian guidelines, the rates of success for an AF ablation in the paroxysmal patients is probably in the range of 60 to 75% and goes up to 75 to probably as high as 90 after 2. This is a pretty good number to quote patients when we see them in the clinic. And for persistence, the rule of thumb is that it's about 10 to 15% less than paroxysmal, and you usually need more than one procedure to get the job done. I think so far what I presented are short-term outcomes. There is some emerging data to show what the long-term outcomes are. I think you have to think of atrial fibrillation as a chronic disease, unlike other types of conditions where once it's fixed, it's fixed. In some people, it comes back. This is a pretty good study, I think, demonstrating the message. In this study, they looked at 123 patients who had a successful ablation with no use of drugs, free of atrial fibrillation in the first year after ablation. They followed them for 5. And what we noticed is that there's an attrition rate of about 5 to 7% a year, in spite of the fact that in the first year, they had no AF. So it goes to show you the progressive nature of atrial fibrillation in some patients and the need for surveillance and long-term follow-up, and probably the need to have multiple procedures later down the line. And I think what are some of the reasons which may account for these recurrences? As you know, we're burning rings around the veins. It's conceivable that we may have some gaps in a little area so that eventually these will break through and result in recurrences. Our lesions may not be durable just because they work in the first few months. As you know, in biology, things can grow back. And I think we also come to realize that not all atrial fibrillation is caused by triggers from the veins. There may be other substrates in the left atrium which account for the pathogenesis of atrial fibrillation. This is a good compilation of numbers. I think what these people did was that they had patients with AF, they ablated them, some had recurrences, and they brought them back to the lab. And what they noticed is that in many of these patients, at least one of the veins have a reconnection. So the veins are not isolated in a majority of the patients who had to have redo procedure because of symptomatic AF. And I think it highlights the fact that the pulmonary veins are still an important trigger in atrial fibrillation, and it speaks of the need to have better technology and strategies to make sure that we have more permanent and durable lesions at the first go-around. I think this is a review of the anatomy. I think it's quite humbling to know that this is complex topography. We cannot burn too deep because we can stenose the vein. So we have to find a happy medium so that we can do the vein effectively without damaging them. As you can tell, the topography is complex, and it's no wonder that with the technology we have, we can leave gaps, unablated gaps, and which may account for recurrences. I think in addition, there are some patient risk factors, which is important in predicting your risk of atrial fib. This is a small study which followed patients up to 5 years. And what they noticed is that hypertension is a risk factor for recurrences of atrial fibrillation. And I think as you see in clinical practice, there seems to be a triangle of AFib, hypertension, and sleep apnea. They seem to go hand in hand. This is just a study looking at the electrical abnormalities of people's atria in those with hypertension versus those without. Just to summarize, they took a number of patients with chronic long-standing hypertension and compared it to people who have normal atria. I want to highlight the areas of red, which represents scar. So what they notice is that people with hypertension tend to have more scar in their left atrium compared to those who don't. This is also associated with some electrical abnormalities in their hearts amongst those with hypertension. I think it lends some credence to our theory that there may be scar, fibrosis in the atria, which may also serve as substrate for atrial fibrillation when you have these comorbidities. This is another example of sleep apnea. So in here, we did mapping of the atria in people with sleep apnea with areas of red demonstrating scar and less so in patients who do not have sleep apnea. Once again, it highlights the fact that these risk factors probably contribute to the creation of abnormal atrial substrate, which may be important in recurrences of atrial fibrillation down the road. And I think to address them, to deal with anatomic gaps in our center, we try to develop better catheter technology and the use of advanced 3D imaging to deal with this. To try to deal with non-durable lesions, we're going to have better technology and more novel energy sources. And we're working hard to try to understand the pathophysiology of AF so that we can select patients better, so that we can get the ones who have a higher success rate. And I think in summary, you have to understand that triggers are important in the initiation of AF, and also you need abnormal atrial substrate, which is contributed by a number of risk factors, which will result in patients having atrial fibrillation, recurrent atrial fibrillation, long-standing atrial fibrillation on a 24/7 basis. I think let's get back to some patient aspects. I think as clinicians, we have to ask ourselves, why are we treating AFib? I think these are 6 important treatment goals of atrial fib: symptom relief, improvement of quality of life, prevention of heart failure, prevention of embolic events, reduction in mortality, hopefully, and reducing healthcare costs. I just want to spend a few slides on the concept of Af ablation in heart failure. As you know, patients with heart failure and atrial fibrillation have a worse prognosis compared to those without. This is shown in multiple studies. And when you look at, however, meta-analysis of clinical trials which try to rate versus rhythm control patients with AF and heart failure, there's no difference in their mortality, as shown by the meta-analysis here. However, there's a lot of interest in using AFib ablation to try to treat heart failure, because there is some studies showing that when you are successful and sinus rhythm is restored, you actually can improve people's left ventricular ejection fraction and make their left ventricle remodel in a positive way. So there's a lot of interest in the community now to try to apply AF ablation in heart failure patients, because we may be able to improve their LV function, which hopefully can portend to better survival. And we'll be one of the important centers in participating in this randomized clinical trial, which is led by Dr. Tang in Victoria. This is a Canadian-led, multi-center, international randomized trial looking at the role of atrial fibrillation ablation in patients with heart failure, comparing to rate control. And the hypothesis is that ablation-based AF rhythm control compared to rate control will improve your cardiovascular mortality. No clinical trial so far has shown that AF ablation can improve heart outcomes, like death or stroke rates. This is one of the many trials which is ongoing to try to address this question. And I think finally, from a patient's perspective, what is considered to be a successful outcome? I think, first of all, patients can experience AF, recurrent AF within the first 3 months after the ablation because of the inflammation. So having an AF recurrence in the first 3 months after the ablation is not really a sign that it has failed. So I tell patients usually we need to wait 3 months before we can truly tell whether the ablation worked for him or her or not. When you look at studies, they define failure as any atrial fibrillation lasting more than 30 seconds on Holter or ECG. I think clinically that might not be that relevant, because some patient, if you can reduce someone's AF from 24/7 to having 45 seconds every month, I think that's a win for the patients. So I think when you look at the literature, you have to balance what is defined as a clinical success, which is a patient-reported outcome mainly, and what is considered a scientific success, which is a ECG AF duration outcome. I think at the current state of things, this is where AF ablation is. It probably makes people feel better, but it has no benefit or harm with respect to your survival. I want to focus a little bit about quality of life because this is probably the only proven benefit of atrial fibrillation thus far. We do know that amongst patients with good outcomes after AF ablation, they have better quality of life. In this study, they look at a number of quality of life indices, and they show that when they have a successful AF ablation, they have better quality of life as defined by the lower bars at 3 months and also in long-term follow-up. So this is fairly well established, and I think it's very correct to tell patients that when the AF ablation works, you probably will feel better about yourself and have a better well-being. This is another trial showing the relationship between AFib and symptoms. I think this is a good study showing that amongst patients who have a good outcome, ablation, less AF recurrences, and they look at the quality of life and the symptoms, those patients with a good, who had underwent ablation had improved quality of life scores as defined by the green bars in 12 months, so better scores than a yellow, which is baseline. They also have less symptoms at 6 months and 12 months, as noted by the reduction of all these self-reported symptoms after the ablation. So I think it's pretty correct to tell patients that if you underwent an AF ablation and it worked, i.e. reduced AF recurrences, you probably feel better and you have less symptoms. And I think this is also important because when you have worse quality of life, Dr. Dorian has published a study showing that your healthcare utilization is more. So I think there's a public health message here. If we can somehow perhaps improve the quality of life and the symptoms, perhaps we can reduce healthcare utilization in these patients, which will have major implications in our health policy planning and health resource allocation. Just a taste of how expensive it is. $6.6 billion was spent on atrial fibrillation in the United States in 2005. Most of it is due to inpatient care. So the magnitude of this disease is significant, and I think as clinicians dealing with AF, we're obliged to try to invent new ways, invent new systems to try to better triage these patients and make them feel better, so hopefully they can reduce healthcare costs on a societal level. So in 2012, we refer patients for AF ablation who remain symptomatic in spite of the use of antiarrhythmic drugs, and we refer, and those are the patients in whom a rhythm control strategy is felt to be better than rate control. And these are the patients I would consider bring to the lab if they're willing. So patients who have drug refractory symptomatic paroxysmal AF, patients with symptomatic drug refractory persistent AF, in whom we know that they feel much better whilst in sinus rhythm. And also, I would strongly consider AF ablation in patients in whom it is a main player in their LV dysfunction. We do have a complex ablation clinic who see AF and VT patients. It's a nurse practitioner / MD model, which are pretty good waiting time. And it's one of our proud aspects in our program. And we follow patients up to a year. And probably even longer, given the data. The key message, final slide, is as follows. Catheter ablation is an effective treatment for patients with symptomatic, medically refractory atrial fibrillation. The incidence of a serious complication is about 1%, and the incidence of any complication is about 3 to 4%. The success rate for patients with paroxysmal AF after one procedure, 65 to 70%. For persistent, a little bit lower, 50 to 60, and usually more than one procedure. And finally, I think ablation has been shown to improve symptoms and quality of life in people, and we're doing ongoing trials to try to show that it can improve other hard outcomes, like stroke and mortality. Perhaps in a few years, I can give another talk on that. Thanks.